The numbers are staggering. An estimated 5% of patients contract a serious hospital-acquired infection. Nationally, an estimated 500,000 patients develop surgical site infections each year, with estimated costs of up to $30,000 per event. Studies also demonstrate about 2,700 instances of wrong site, wrong procedure, or wrong person surgeries occur annually. While the nation's hospitals still struggle with other adverse events such as surgery-retained foreign objects, and even basic fundamentals of safe care, including hand hygiene, and the cleaning, disinfecting, and sterilization of medical supplies and equipment. In March of 2013, North American Partners in Anesthesia, the leading single specialty provider of anesthesia services in the U.S. and the exclusive provider of anesthesia services to the North Shore LIJ Health System, designed and implemented a program to introduce remote video auditing in operating rooms at Forest Hills Hospital in Queens, New York. This program is an expansion of a video monitoring system first introduced in the North Shore LIJ system to improve hand-washing compliance. The partnership between NAPA, North Shore LIJ, and Aerosite, a developer and third-party provider of remote video auditing, saw hand-washing compliance go from under 16% before remote video auditing to nearly 90% after. Building on the success of that program, NAPA took a leadership role in developing the pilot program for the OR. This program marks the first time that remote video auditing has been used in the surgical setting.
We believe strongly that by using this tool, we'll be able to show through our research that it improves patient outcome. Our initial reason for using the remote video auditing was primarily as a safety tool. We wanted to be able to give people feedback in ways that would improve patient outcome. But remote video auditing is capable of doing so much more. It allows us to objectively measure things that for years we thought we were objectively measuring, but there was always some bias.
This project has both the OR efficiency component and a patient safety component. And the patient safety component is very, very important. And that relates to the issues of sign-in verification, timeouts, and sign-outs. Compliance and rigor in doing those pieces has been shown to be essential to patient safety, just like in a cockpit, it's essential to commercial aviation safety record, and we'd like to bring that to medicine.
One key patient safety issue addressed by this program is conducting a timeout before each surgical procedure.
Are we ready for timeout?
Yes, we are, Doctor.
Please introduce yourselves and your roles, please.
Dr. Conti, the surgeon.
Denise, the circulator. Luis, the PA. Gabriela, practice.
John I. Mateo, anesthesia. We're going to identify the patient with Dr. Conti.
A critical step in the process was to identify the anesthesiologist as the logical candidate to take leadership in implementing the timeout in the OR.
By doing something as simple as getting everyone to communicate effectively through a scripted checklist to make sure that you cover all the important basic safety steps that a team may think is important in their center, that you're more likely to actually avoid missing a step.
We measure certain things such as whether the employees are paying attention, whether the duration of the timeout is sufficient to be able to ask all the questions that need to be answered. And we've seen quite an increase in improvement in compliance, so that's been very impressive.
Published studies have shown that, on average, many hospitals do not conduct a proper timeout prior to a procedure nearly 20% of the time. Within a single week of implementing this real-time performance feedback, the 8 ORs at Forest Hills Hospital achieved nearly perfect scores complying with this part of the universal protocol. Immediately following a surgery, a sign-out occurs.
At the end of the case, the circulating nurse, the surgeon, and the anesthesiologist communicate to a sponge count, to an instrument count. And this reduces the possibility of retained instruments or sponges in a patient. It gives us a final count of blood loss, and it gives us an indication to will the patient be needing any more blood as moving forward into the recovery room. Also, disposition of the patient. Will the patient be going straight to the recovery room, or will the patient be going to the ICU or a step-down unit?
Sign-outs are important because it encourages communication at a very important period in patient surgery. At the end, we discuss during the sign-out, what have we done? Are there any patient-specific concerns? Have we accounted for all the equipment that we've used in the surgery? And very importantly, where is this patient best served postoperatively?
An additional key patient safety issue addressed by the program include terminal cleaning compliance.
From an infection control point of view, which is also patient safety, we're watching how we clean the rooms in between cases. Are we cleaning them correctly? Are we spending enough time in there? Are we pulling out everything that needs to be pulled out and really wiping it down?
Forest Hills Hospital was particularly interested in seeing if remote video auditing could be used to improve how the operating room was cleaned between procedures and at the end of the day. The cleaning checklist includes 10 items, and each must be completed and verified. Before the remote video auditing program, the hospital's compliance rate was 0%. With the RVA in place, they are achieving virtually 100%.
From an efficiency point of view, which is also important, and a physician satisfaction point of view, we're seeing how we turn over the rooms. How long does it take to get the equipment in after the room's been cleaned? How long does it take to get the patient in after the room's been cleaned? And these are important in efficiency and in controlling our own costs.
Aerosite has a very good system for making sure that data is accurate. And it takes away that judgment piece of the actual milestones we do.
The recorded video blurs everyone's faces so individuals can't be identified. This and other measures assure healthcare practitioners embrace the data and be motivated to both improve patient safety and manage the operating room in the timeliest manner possible. Early indications from this program show that OR turnover time can be potentially decreased by 25 minutes or more per case. This could translate into a significant increase in revenue for Forest Hills Hospital. An added benefit is the satisfaction that surgeons and anesthesiologists feel when their downtime between cases is minimized.
We should care about whether we're spending a half hour longer than we really need to take care of that patient safely. What wasted time can we somehow remove? Those dollars that are saved through improvements in OR efficiency turn out to be dollars we can use to reinvest in the system to protect patients in other ways. Throughput and efficiency in the operating room is mandatory today. Society is asking us to provide high-quality care at a lower cost. We can't afford high-quality care at an escalating cost anymore, and we've already reached a point where society is saying it's enough. And so the real challenge for all healthcare systems is to figure out a way to improve quality with less.